Okay, and we are live. Hello.
Hello.
Welcome, everyone. This is Dr. Sarah Merritt with Lifestream Health Center, and I am excited to be here on a live with you once again. Um, and I have my guest here today is Dr. Toyosi Onwuemene. Did I get it? Or can
It's
you do it
good. Yes. Onwuemene.
on Wemina? Thank you. Dr. Toyosi is a hematologist and practices at Duke University Medical Center. Is that correct?
That's correct.
Yeah. And she is a researcher and really a physician scientist and treats patients, but also has many facets to her practice. So I'll let her tell us more about that. But I'm Sarah Merritt with Lifestream Health Center. We offer chronic pain management, acute and chronic pain management. Our clinic is in Maryland. We're in Bowie in Central Maryland, and we're really working to make pain management caring, accessible, patient-centric, and evidence-based. And so we treat a variety of patients and pathologies. But one of the really challenging pain pathologies that's out there is pain from sickle cell disease. And so patients who have this genetic condition have some severely painful episodes through their lives. And so I would love for Dr. Toyosi to tell us a little bit about how she helps patients.
Absolutely. Dr. Merritt, thank you for having me.
Glad to have you.
So, I am a hematologist. That means that I take care of patients who have blood disorders. And so
Mhm.
that's anywhere from people with iron deficiency to hemophilia, bleeding and clotting type disorders, and also sickle cell disease. And I do work in an academic medical center, and my primary clinical is really rounding in the hospital, especially helping to train fellows as they are also learning to be hematologists as well. So it is in the hospital setting and also in the emergency department setting that I happen to manage and help take care of patients with sickle cell disease. As you know, sickle cell disease is a disease that really is characterized by chronic pain. But the underlying problem is that patients have a fundamental problem with the genetic code for hemoglobin that
Mhm.
makes the hemoglobin not stable. And so, in the sense when patients get stressed, their cells get deoxygenated. Instead of the red cells being nice and flexible, they become stiff and rigid, and they block up places, and they block blood flow to the places, and then they don't deliver oxygen as well. And so, the pain of sickle cell disease is just a lot of infarction. That's just tissue dying, and it's pretty severe. It can happen acutely. It can keep going chronically, but it is one of the most important reasons why we see patients with sickle cell disease in the emergency department or in the hospital.
Yes, yes. And hopefully, if we're doing a good job treating these patients clinically, then again, pain may be part of it. But I mean, these infarctions or these episodes where there's inadequate blood flow, I mean, these can be life threatening, even, right, if they're untreated.
Absolutely, because the blockages and the ischemia and the infarction can happen anywhere in the body,
Hmm.
including the brain, the heart. It really can happen anywhere. So, part of, as you touched on, the management is making sure that we're actually addressing the underlying disease, decreasing the number of these episodes that they have, and also managing the pain crises when they happen.
Yes. Um, Thank you. And so, what about briefly, just to touch on maybe the more common condition would be sickle cell trait, which is a patient who has some sickle cell hemoglobin in their body. Do those patients have crises or episodes like a sickle cell patient with that you were just describing?
That's a really great question. Yes. So, as you mentioned, a patient who has sickle cell trait does have some hemoglobin S, that's sickle
Mhm.
hemoglobin, but it's a much smaller level or much lower level compared to patients who have sickle cell disease. For that
Mhm.
reason, they do not have the manifestations of chronic pain and vaso-occlusive crises like patients with sickle cell disease do. In fact, sickle cell trait is not considered to be a disease for which patients need treatment. It becomes important when partners are thinking about having children together and making sure that the child is not born with disease if both partners have trait. But in general, this is not something that patients have to take special precautions for because they have trait. That being said, in
Mhm.
cases of extreme deoxygenation, so for
Mhm.
example, people who are hiking high up in the mountains or they're
Mhm.
outside doing football practice in the blazing hot sun and they're not
Oh, wow.
hydrated, they can have some kind of hemolysis that's associated with just severe dehydration and stress.
Mhm.
But these are very rare episodes. And so, in general, most patients don't have trouble with sickle cell trait.
Got it. Yeah, and so if you were a person with sickle cell trait, you would want to not become a mountain climber for Mount Everest, or you would maybe want to direct your efforts towards something else.
You would talk with your doctor and come
Talk
up
with
with
your
a
doctor.
plan.
Yeah, think about other goals maybe.
Yes.
Okay, very good. Well, so let's talk about how patients. So it's good to hear. So I certainly have patients who have sickle cell trait in particular, right? Is maybe more common than having true sickle cell disease. Um, but how do these patients, what are the ways that a person with sickle cell disease can help better live with this problem? Because while it is a genetic condition and it's something that a person would have all the time, um, there are ways to maintain your health, I think, to help avoid crises. Is that correct?
Yes. And it's really important that you ask that. So, patients with sickle cell is kind of a heterogeneous disease. People have different manifestations, and some people have very few manifestations, while others are in the hospital and out of the hospital a lot. And so, different people experience the disease differently. However, everyone who has sickle cell disease has the opportunity to help work to help manage their disease. So, number one, it is important to be plugged in with a care team, and that does
Mhm.
involve being plugged into your primary care provider and also meeting regularly with your hematologist. And part of that is because there are many what we call disease modifying therapies that are available to help
Mhm.
decrease the number of vaso-occlusive crises that patients have. And really, from an early age, everyone should be on a disease modifying therapy to minimize these vaso-occlusive crises. But what are other things you can do in addition to therapy? Part of it is avoiding stress in all forms. So, really avoiding the extremes of weather,
Mhm.
avoiding the extremes of stress, job related stress, life related stress, and then staying hydrated as well. And definitely keeping up with activity in terms of exercise. And those are things that can
Mhm.
help, especially where there are low levels of pain. Sometimes distraction and exercise can be part of the management strategy as well. But I think the big things for patients are making sure that they're plugged in. Some
Mhm.
patients we only see when they are in an acute crisis, and then they show up at the emergency department. They don't have a team that helps to support them between those visits. And so that's important, and caring for ourselves in terms of avoiding stress and staying
Mhm.
hydrated.
Yeah, and some of these things, it's kind of making me think about. This sounds like a condition where those social determinants of health might be really big, right? Where a patient who's not in a position to take good care of themselves due to socioeconomic status or other reasons, might really be in a more challenging position to maintain their disease.
That's a really great point. Absolutely. Sickle cell is one, I think, of many chronic diseases where you really need a great support network.
Mhm.
You need a great support network in healthcare, you need a great support network in your community, and you need a great support network at home as well. And so any challenges to your social networks and structures really mean that in general patients tend to have poorer outcomes. And then there's also the added component of showing up to the emergency department, sometimes not being believed despite having severe pain. So there's a mental health component that comes along with that as well.
Mhm.
And so it's so important that patients are surrounded by as much help and have the resources necessary to continue to care for themselves well throughout this illness.
Yeah. Yeah. Thank you for that. For sure. Yeah. And it just makes me think about, yes, that patient in the emergency department who's having severe pain that's looking for treatment. And that treatment might involve IV fluids would usually be a mainstay of initial treatment in this type of crisis. Potentially pain medications, maybe opioid or IV opioid pain medications to get the pain under control. These would be pretty standard therapies considered needed. But I hear you, and I think this is a time that it's challenging for patients. I think if I speak with patients about bias that they might experience in the emergency department, I think probably all patients seeking pain relief are at risk for some anti-pain bias, and then maybe particularly a person with sickle cell where there are a few markers, I think. Is that correct? Like the person has sickle cell disease and that might be reflected in their chart, but are there ways that the patient can substantiate in some way for their team that they're having pain? I mean, I think it's really just a self-report, but you tell me.
Yeah, this is one of the many areas that's ripe for research in sickle cell
Mhm.
disease is how do we find biomarkers that help us understand, number one, how
Yeah.
severe a patient's pain is, and then how to see how they're doing as they're receiving treatment. And right now we don't have any markers that are known to help us do that. And so really we are 100% reliant on the patient's
Mhm.
self-report. And that can be challenging because really over the course of a patient's experience of this disease, many times they do exaggerate so that they can get attention because they're used to not getting the attention that's needed. And I think it's a challenging situation because as providers we do need to give patients the care that they need, and patients don't always feel heard and they don't always feel listened to or accepted. And so yeah, it's a challenging thing. It really is self-report, and we do have to rely on that.
Yeah. Yeah, and in my experience of caring for patients with sickle cell, also that very often because they've had over a lifetime, numerous exposures to higher levels of opioids, they're just very tolerant to them. And so, while it might be appropriate to give them an opioid for pain, it's going to take a bigger than average dose, and then that is challenging for the providers to like reconcile themselves with that, and then challenging for the patient who's needing their pain treated.
Absolutely. I think it's understanding that many of our patients at home have a baseline level of opioids that they take. And so when they're coming in for an acute pain crisis, we really want to exceed the baseline level by at least a factor of 15 to 20%. That's something that's very difficult for providers where already the baseline dose of opioids is more than they've ever written for any patient, and they
Yeah.
don't even want to do that. And so patients are leaving their homes, coming into the ER, and sometimes receiving less narcotic treatment than they had been getting at home. So it's challenging because
Yeah.
I think in general, and because this is what you do, it
Yeah.
is difficult for physicians to treat pain well. And I
Mhm.
don't think it's a
Yeah.
great thing that we get trained to do, but it
Mhm.
definitely is challenging for both patients and providers.
Yeah, yeah, and I would say that's like ABCs of pain medicine as a physician for that patient with chronic pain of whatever variety, who takes a daily opioid. That yes, you need to just acknowledge and know in your mind that they need that entire amount of medication and then additional to treat beyond that.
Mm.
Yeah, that's great. Well, let's hear more about opportunities for research in sickle cell because I don't know anything at all about it, but this is certainly your area, and I think it sounds to me like there are a lot of opportunities to improve care for patients with sickle cell in probably numerous ways. Tell us about the research and how you work on these problems.
Sure, sure. So I want to thank you for bringing that up. And I think it's so important because really throughout hematology, there are so many opportunities for us to advance the science. And
Mhm.
really, we're waiting for people to step into leadership and help us do that. So, taking sickle cell, for instance, the question you asked about how do we have biomarkers that help us understand when pain is severe and how patients respond? This is something we don't know. And it's definitely an area that's ripe for research. And part of the challenge, I think, is that sickle cell is a rare disease, and many rare diseases are chronically underfunded, and there are not a lot of providers in the space who are able to move the work forward. And that's why, as a coach, I help clinicians who want to make the transition to research but don't necessarily have the traditional structures in place. Because I do think that clinicians who are at the forefront of patient care really hold some of the keys to major transformative strategies that we're going to see in the lives of our patients. So definitely we need strategies to improve our understanding and measurement of pain. We
Mhm.
need other therapies. I think that there are definitely a lot of challenges surrounding opioids as a primary strategy for
Yeah.
pain management. I think, as you know, I think thinking about what other strategies can patients employ, and their providers as well. And then there's also the concerns around acute versus chronic versus acute on chronic pain. And how do you prevent patients from moving from acute episodes of pain to now acute on chronic, or to now chronic pain, where the pain signals don't turn off and they're constantly firing. And so, I mean, just in general, there's so many opportunities for research in sickle cell. And I just want to encourage as many people who are interested. You may have younger patients in your audience who are like, when I grow up, I want to make a difference. I think
Yeah.
that really clinicians moving into research is going to be a big game changer for many of these rare diseases, and
Mhm.
especially for sickle cell.
Yeah, I think that's exciting that there are opportunities and a lot of big questions that probably have some answers, and probably there are improvements that may not even be far down the road, but we do have to take those steps to get there.
Absolutely. And, it's really a partnership between patients and providers, because I think as patients are helping us understand their experience, and, we prescribe these disease modifying therapies, and it's really important for patients to take them and to let us know if they're not able to take them, what are the challenges they have in taking them, what are their side effects they're experiencing, or what are the
Mhm.
beliefs that they have where they don't feel like they should be taking the medications. There's definitely a lot of mistrust in the system in general, but especially among patients with sickle cell disease. So I just think there are opportunities for patients to partner with the providers as well, to help answer questions that help patients move forward.
Yeah. Yeah, that is so interesting. I think, and I certainly see that in pain medicine as well. That even if a patient has a significant painful condition, just a general reluctance to take medications. Is this really necessary? And then in the case of someone with sickle cell disease, that yes, there might be additional distrust of the system or other layers, even beyond just maybe not wanting to take a garden variety medication. Um, yeah, I think that partnership sounds like probably the way that you're able to work with that and move things forward for patients.
Absolutely.
Yeah. Well, and I'd love to touch a little bit on some of those non-opioid therapies for pain. Then again, as you brought that up, um, so the therapies that you discuss and educate patients on include hydration, avoiding excessive stress, and I guess that's physical and mental stress. You said correct?
Yes. Yes.
And then what am I leaving out?
Hmm.
Are there
Exercise as well. That's
exercise?
important.
And so
Hmm.
tell me about exercise. So obviously there's such a thing as overdoing it, and you kind of gave that example of excessive heat, super hard workout. That
Mm.
could be a negative for a sickle cell patient. What are examples of exercise that are probably in the safe zone?
I appreciate you asking that. I think in general it's not overexerting yourself. I think it's
Mhm.
really simple things like getting up and walking and making that a part of your daily routine. I do have
Mhm.
some patients who are in the gyms, like not overdoing it with the weights, and making sure that you are listening to your body when you feel like you're at the point where you're overexerting yourself. I think what's important is that patients are not sedentary, that they're up and they're moving
Yeah.
around, because that's helpful in terms of distracting sometimes from the pain as well, and keeping them kind of just overall healthy in mind as well, which is important in any condition where there's pain.
Yes, for sure. Yeah, and as we're speaking on this, yeah, I would say this is so on point with the same kind of ABC fundamentals of good self care for pain and for being a human, really, of being as active as possible, because the body is kind of a use it or lose it thing, and what each person's possible is going to be different, right? That certain people will have higher limits, but even just to work in that safe zone is just, I think, so valuable for patients to learn to walk and do whatever mild exertion is possible and appropriate for them. It's so important.
Absolutely. And I think, at the end of the day, you never want to limit a patient. So as much as you can do, you absolutely
Yeah.
should, in
Hmm.
partnership with your providers as well. So if, for
Yeah.
example, you're feeling up to running a marathon, that's a pretty big stress on the body, and
Yeah.
would be the kind of thing that you should talk to your provider about, and have a plan for, if you are going to do it, how to be safe and how to know if there are any warning signs or concerns. So those are the kinds of things that ultimately, no exercise is off limits. However, it really
Mhm.
is important that you talk to your provider and come up with a strategy.
Yeah. Yeah. And kind of, I guess a patient would have to learn this on their own to, how far is too far, or what's the
Mm,
stretch, or what's too much. Because certainly, um, we all, anybody might feel some discomfort during a workout or
mm.
a session of exercise, but um, what is a real sign to stop versus what is just normal.
Yeah, and again, it's an area that's definitely has a lot of ongoing research as to what is the optimal exercise strategy to help
Yeah.
improve pain. Mm,
Yes. Yeah, I would imagine, certainly for chronic low back pain, we have studies looking at um, gentle yoga, Tai Chi, chair yoga. I think these are probably exercises that would have some overlap for a sickle cell population that wouldn't be excessive, but could be helpful in terms of mobility.
agreed.
Yeah. As we're talking about those non-opioid therapies for pain, I wonder too. So I'm an anesthesiologist and I'm board certified in interventional pain. Also, through the years of my practice, we've actually added ketamine infusion for chronic pain and for depression to my practice, to the practice at Lifestream, and we've been so impressed with some of the results that we've seen. I wonder, have you administered this in the ER? Is this is a ketamine is a hot topic in the pain and depression world. It's not an opioid, and it seems to have some profound effects on pain and mood.
Yeah, I'm glad that you brought it up. Definitely. So we partner with anesthesiologists like you in taking care of our patients with sickle cell, and ketamine infusions are certainly one of the strategies that is used in our patients with sickle cell. I will tell you that how patients respond is variable. Some patients love ketamine and others hate it. For
Mhm.
those who have not had such a great experience with it, I think they worry that they have hallucinations related to the drug, and
Sure.
I wonder if that's something you've experienced with your other patients who are on ketamine.
Yeah. We do administer ketamine infusions on an outpatient basis. And so my experience of treating the patients is that they may come for the infusion. And it's been interesting because as I speak with patients who have had a series of infusions or a number of infusion, their ketamine experience, so to speak, um, it's not uncommon for them to say, man, I really do not enjoy the experience of this infusion, but the results are so good. So,
Mm,
like, I have a patient with
mm,
CRPS of the foot, and her whole infusion experience is generally kind of unpleasant and anxiety provoking for her. But she goes, I've seen her need crutches to walk in my office, and then that was pre-treatment and when she was in a challenging spot, and now like when she's good, she can ride a Peloton and do like things anybody can do. So it's a pretty big difference in the
mhm.
management of her pain. So that's what I've heard is for the people where they have that profound pain effect. It does. I've had multiple people acknowledge like that transient discomfort of the infusion is worth
Mm,
it.
mm. Yeah, and thank you for sharing that story. I think it sounds like for everyone, there's an opportunity to tailor a pain management plan, of which
Yeah,
ketamine could be part of that plan as well.
yeah, yeah. And I think it's just opioid sparing, which is maybe
Mhm.
what people are excited about. And you know, I would say I'm an opioid moderate. I think there are conditions that people need opioids for, right? And we shouldn't act like they're not useful medicines, right? They absolutely are. But to the extent that we can limit them, right? Because this is the challenge for the sickle cell patients in particular. They're just an example of a patient who gets very often these patients are exposed to multiple exposures to high dose opioids, and frankly, it's kind of the medical system develops almost a dependence for them, right? I mean, I think there are
Mm,
patients with sickle cell who, as I'm aware of, have developed opioid use disorder or a problem with opioids, and it's really just induced by the disease that they have and the medical treatment of it.
absolutely. I mean, you make a really important point. I've had patients call me saying, "I miss picking up my prescription. I'm in withdrawal. Help
Hmm.
me."
Yeah,
And patients don't wanna be there.
yeah.
And so I agree. I think that as many serious, opioid-sparing therapies as we can develop and move forward in our patients will actually benefit both patients and our providers as well. I think we are far from that place, but definitely that journey is important and must continue.
And I wonder, do you have patients with sickle cell that use buprenorphine for pain or just for withdrawal management, maybe, or both?
Yes, I'm so glad you mentioned that,
Yeah.
absolutely, and so we do have a buprenorphine program at our hospital,
Mhm.
and, many of our patients have successfully transitioned to it, and I think it's a good strategy all around, so
Yeah.
absolutely.
Well, and this is super interesting for me just as a prescriber. And we prescribe certainly opioid medications, buprenorphine, depending, on the needs of the patient. As you know, the DEA has taken away the X waiver for buprenorphine recently, and so it's for those of us who do, prescribe as part of our practice. It really opens up, I think, in certain ways, the ability to treat more patients and treat patients better, to offer it more. I think previously, um, there's just the regulations around buprenorphine were sort of limiting, and this is going to, I think, open it up in a way, because otherwise, I think the medication would became almost stigmatized. This is for addiction,
Mhm,
um, right? If
mhm.
that's the rules around getting the prescription filled, where the pharmacy is the most comfortable with that. Whereas now, I think we can better make it accessible. That hey, this is an option that may treat your pain and may help manage withdrawal. Let's see if it's good for you.
Absolutely, I think it's a step in the right direction.
Hmm. And then if you had a sickle cell patient that had a crisis, would this be a situation where you might take them off the buprenorphine for a little while to use a C2 opioid or a different type of opioid, or would they just continue their buprenorphine? I'm curious.
That's an interesting question. So for many of the patients I see them in the inpatient setting where they're kind of like have pain above their baseline or normal. And so yes, for those patients, we're kind of acutely transitioning them. Actually, I would say that every patient has a pain plan that's very specific to the patient.
Okay,
And so there is never an automatic like, okay, there's a strategy. Every patient has a strategy. And so they come into
sure.
our ER or sometimes they're not even at our local ER and the docs are calling and saying, what's their primary strategy for when
Mm,
they're in acute pain? And so,
yeah.
certainly for a lot of our patients, that does involve transitioning to a PCA, a
Uh-huh.
patient controlled analgesic pump. But for some patients, it doesn't involve narcotics as well
Mhm.
at all. And for patients who've had a history of opioid dependence and have struggled in the past, we do as much as possible use opioid sparing therapy. So every pain plan is individualized to the patient.
So interesting. Yeah, that's great. Well, and I would say, just as a anesthesiologist and pain doc, the recommendations around, I would see a sickle cell crisis as being similar in some ways to like having an operation, or, it's a time that you might go into the hospital and need some extra medication. And the recommendations around how we handle surgeries and stuff has changed to where very often patients continue buprenorphine through a perioperative period. So I just wonder for those sickle cell patients, yeah, they might be able to continue their buprenorphine depending on their pain plan, it sounds like.
Yes.
Super interesting. Um, well, Dr. Toyosi, what else do you want to leave our audience with? What have we missed, or what else do we need to talk about?
Well, I think one of the things you kind of highlighted without necessarily saying it exclusively or
Mhm.
explicitly is just how important it is for patients to just have a team of doctors working for their benefit. So, I mean, you think about having a primary care provider, having a hematologist, but also having your anesthesiologist, your pain doc involved in your care. For many of our patients, we do send them off to our collaborators, our pain docs, who help them manage their pain. And so I think I would just say to your audience, and I mean, they're already kind of engaged with you, but for as many as are not, and you don't have a pain doc as part of
Yeah.
your pain management strategy, I think it is important because pain management is specialized, and I think you really do need an expert that helps you to really come up with a pain plan that works for you and in your life where you are. So that's what I wanted to share.
Yeah, thank you. Thank you so much. Appreciate it. Yeah, we love to work collaboratively with patients too. And it sounds like thank you for the work that you do and moving the research world and patient care forward for patients with sickle cell disease and other problems.
Absolutely, it's a pleasure to be here. Thank you for having me.
Yeah. Well, thanks everyone. Thanks for joining us. I'm going to wrap us up. So happy Friday. It's been Dr. Sarah Merritt and Dr. Toyosi. You're going to say it for me?
Haha, on webinar.
Onwuemene, because I don't want to mess it up. Um, Dr. Toyosi Onwuemene here from Lifestream Health Center. Thank you so much.